Well, thank you so much. We have 45 minutes for this dialogue between Ellen and Lloyd, and just building a little bit on the previous session. The role of litigation is particularly challenging either the compliance or the definition of essentials medicines lists. This is particularly happening in Latin America, where several countries here are represented. We have been asked to speak a little bit slower, all of us, so we promise to fulfill that request. So here we have a person, which is Lloyd, that has not only thought through the creation, the design of essentials medicines list, but has actually done it in practice for many years. And we have here Ellen, who represents GSK and pharma industry, and we are going to discuss with her and with both of them the role of the pharma industry in precisely defining and implementing and complying with essentials medicines list. So let us start, Lloyd, with you, if you agree. We've been discussing about human rights, and we really want to know from you, what is your perception of the role of essentials medicines list in the national formulary in fulfilling the right to health? And if you can elaborate a little bit on the difference between the two of them.
Okay, thank you. We have changed the format. There is no slides, and that's been informed by the last 2 days' debate. So let me start by saying, what is an essential medicines list? And do we all understand what it means together? And I'm not convinced that we do. The definition of an essential medicines list is that it's population-based, that it's disease prevalence-based, that it's cost-effectiveness-based. And the question is that may not be compatible with an individual's right who has a disease of low prevalence. So I think we need to understand what we mean by an essential medicines list and understand from where it came. The issue is that the impact of an essential medicines list on our population is very, very significant. And it has a great impact on the social structure and social well-being and social outcome of using essential medicines. But we've got to make sure that we understand the difference between an essential medicines list and a drug formulary. Because I think most countries have an essential medicines list, but there's also a national formulary, which may include drugs from the essential medicines list. So if they differ, if an essentials medicines list differs from a national formulary, why? Why is it different? That's the first question I want to raise. The second question is that if we believe that essentials medicines lists are important, and I don't think anyone disagrees with that, then why is the accessibility in most of the developing world so poor? Why is the accessibility, which includes availability and affordability, less than 50% in the public sector and 60 to 70% in the private sector? These are essential drugs, and yet we're not delivering that. So that's the first question. The second question, why is the accessibility of essential medicines throughout the world, particularly in the developing world, so poor? Why is affordability so variable, even within a country? What are the political processes that impact on that accessibility? What is the political will that actually drives the whole variability of accessibility from a national policy? Then the question is, well, how do you develop a national medicines list? Who should develop it? What should be the legislative framework in which it operates? And again, that's highly variable, and Leo's asked me to very briefly talk about Australia, which I'll do in a moment. But the question then is, what needs to be evaluated on what framework it needs to be evaluated, what does independence mean, etc. So let me very quickly, in a couple of minutes, talk about Australia, and only because I've been asked to talk about Australia. I don't mean to say that this is the best system. We are a developed country. We have problems in maintaining and sustaining health delivery to our people, like the United States, like Europe, like every country in the world. This is not unique. This is a universal problem. But we started this independence of an established medicines list in 1953. So we've been doing this for over 50 years. And one of the issues around that is that it must be seen the decision-making about what drugs should be on a list should embed the principles of human rights. So one of the issues about litigation seems to me occurs because the system has taken its eyes off the human right ball, if you know what I mean. It's because human rights have become not a focus of many of the structures that we've put in place. So if you're going to have an essential medicines list and you need a group that actually makes that decision, it must embed itself in human rights. That is, of fairness, of equity, of non-discrimination. All right? Now, the way the system works in Australia is that there is an independent statutory authority that makes recommendations to government as to what would be on the list. It is independent of government. It's made up of consumers, of health economists, of clinicians, of pharmacists. And they make recommendations to the government. Now, they do that on the basis of data which is presented mainly by manufacturers, by the pharmaceutical companies, but not necessarily so. An example, we are about to consider the subsidy of, that is, putting the drug on the national list of RU486, the termination agent. All right. Now, that submission is not coming from a drug company, it's coming from a consumer group that has collected the data and is putting the argument to government. There must be legislation which supports it. In Australia, if the committee makes a decision to say to the minister, no, this drug is not cost effective, the government cannot list it on the pharmaceuticals list. Right? That is in legislation. The issue around the processes of how do we make those decisions, we make them all on cost effectiveness. We consider every drug. So we can't discriminate on whether or not we will only accept drugs of this disease. Any drug that submission comes forward must be looked at. Whether it's an orphan drug, whether it's a huge population, it's non-discriminatory in that sense. The same criteria is used. Now, agencies around the world will differ. So if I compare myself with the Australian system with the British system, NICE uses
can I pause you for a second, just to highlight? At least I was trying to take some notes here. I guess what you're saying is that, from your perspective, essential medicines lists are essential for human rights. That it is important to understand how they are developed, how it is important. And you're also saying that just the fact that you have an essentials medicines list does not translate into immediate access. And that in Australia, the way you've developed has been through an independent committee that has technical provisions that uses rights-based approach, but also takes into consideration some cost-effectiveness measures. So you're talking about the what's and the how's you've done it. And now you're getting into the international arena.
Well, the issue what I'm trying to compare is, if you're going to use cost effectiveness, that means what is the incremental benefit worth the incremental cost? It's as simple as that, basically. But if in the United Kingdom, for example, there is a fixed threshold, which is roughly GDP per capita. In Australia, we do not use a fixed threshold. We take into account social values, which picks up again these issues of human rights. So if a cost per quality is high, but it's the only drug to treat this there's a huge unmet need, then we may accept the drug at 60 to 70,000 per quality adjusted life year, as opposed to a norm which might be 40. There are differences around the country. I mean, again, what I'm trying to point out, I think, is that an essentials medicines list and the way it's developed and the structures in which it's developed must take into account social values, and there must be, if you like, flexibility in order for the decision maker to do that, both implicitly and explicitly. The issue around consumer involvement in the process, we're not as good as some of the other major developed countries. We're improving that. We have a consumer who's a full voting member. It's not a token. He at the moment he is a viable member of the committee. But the question about what we've started to do is to ask patient groups, not do you want this drug, yes or no, because they'll always say yes, naturally. What we say, what is it like for you, your family and your carer living with this disease? So we're trying to pick up, those social values in a way which is much more overt. And I think that's something we all need to think about in the decision context. So the other question I want to raise is if health technology assessment is to become more common internationally, and it certainly is, how can we, and I think a group such as this has got a very good voice, how can we increase the cooperation and improve the efficiency of that technology process, particularly as it's developing, as we develop the skills, as we develop the workforce? What is the international dialogue that we need between ourselves, between pharma and ourselves? How do we do that in an open and transparent way? The system has worked in Australia very well and continues to work well, but it's increasingly under pressure, like every system in the world. So we've got to be much more strategic of how we do this. All right? And prioritisation will be necessary, but we must do that as a collective, not as a committee. Leo, that's what I want to say. I'm still very frustrated as a member of the world why in some of the developing countries corruption in that is having a negative impact on accessibility, why the quality framework is wrong. And we'll hear from Ellen about how we need to work with industry in promoting these things in a way that we thought before, can't go there. We've got to become much more aware of what's going on, accept everyone as a stakeholder, give them rights, but hold them accountable for their actions. And that's the process, I think. It's a new paradigm that we all need to go forward with, and we do it collectively. Because if we don't do it collectively, we'll end up with a fragmentation.
Thank you, Lloyd. Turning over, I saw Ellen's hand raised when Lloyd was commenting some social values and processes. Thank you, Ellen, for being here as part of this global discussion. Organizers acknowledge that industry is a stakeholder and should be present in this discussion, in as much as civil society, public sector, judges, and so on. And as Lloyd was saying, stakeholders have duties but also rights both. So we've been talking about access, we've been talking about human rights. You coming from GSK, you coming from the pharmaceutical industry, how do you see this discussion? What can you do from your sector to promote access, particularly for the most vulnerable?
So it's a great question, and so I have to I do have a great question. I think I want to be your first question in the discussion. But I was at our table this morning when we were thinking what are the big questions on our minds, and I wasn't able to completely connect the human rights systems approach to the delivery of healthcare. And I have to say, Saeed, the iceberg diagram did it for me. And I want to spend a few minutes telling you a little bit about the mental map of people who work in the pharmaceutical industry. Because what you see is a company interested in profits, fighting about price, seeing as a barrier to access. And all those things are things that you would see given the problems you have to face in your countries. But the people who go to work in these industries every day, many of them, and I've been in this industry for 22 years, their mental map is to deliver medicines, vaccines, healthcare to people. That's why our commercial colleagues don't sell cars, they sell drugs. That's why those of us who love science want to cure disease. And those of us like myself who are physicians, and I am a medical doctor, and I started my life in public health, working in HIV, want to see populations benefit from the technology and what science and medicine has to offer. And there has never been a better time. The reason this is so complicated, we have so many medicines. We have technology. We have communications. And I think to myself, if Coca-Cola is in every village in this world and is kept cold, why can't kids have a vaccine? Where is the cold chain for that? So that gives you a little insight into my mental map. And I just wanted to share a little bit of the mental map of people who have led pharmaceutical organizations now and in the past. When I joined Merck in 1991, I came there out of my public health background to work on HIV and blinding eye disease because I'm an ophthalmologist. But at the time, Roy Vagelos, who was running that company, they had also decided to begin the donation of ivermectin for onchocerciasis, which many of you know is a cure for river blindness. Roy had a habit of meeting new physicians in the company. You had your 15 minutes with Roy, and you got to ask him any question you want. And I asked him, I said, so Dr. Vagelos, how long will you give away ivermectin? And he said, I will give it away until the disease is gone. And I said to myself, if I'm going to work in a business, I'm going to work in a business that has a leader like this. And at GSK, we have such a leader, Sir Andrew Whitty. And for the last 10 years, just to give one example of what our company has done, we've given away 3 billion tablets of albendazole for elephantiasis and now for the deworming of children. So part of this was to go back to also a request that was made earlier by our organizers. This is a little bit of a personal story, but you have to know why this is personal to you. And I've woven into it, I hope, some examples. Now, what you have on your table, I'd like you to all, if you could find these papers and look at this one that says the London Declaration for Neglected Tropical Diseases. And of course, that is much of the work that I'm now engaged at GSK. In 2010, Bill Gates convened a roundtable of CEOs. Sir Andrew was the first chair of this. It rotates among the different companies. And up for discussion are a variety of issues that he believes pharmaceutical companies should be stakeholders to address. And Margot, I don't know where you are this morning, but the first thing you said, and when you talked about the human rights approach yesterday, was that the most marginalized, the people who are neglected, that no one cares about, where the medicines may not have any commercial value, how do we take care of them? And that is the 1 billion people who suffer from the WHO-defined 17 neglected tropical disease. And in January of this year, 13 companies, the United States, the United Arab Emirates, the UK, the World Bank, the Gates Foundation, and other stakeholders, and you see on the left-hand side of your paper, all the stakeholders have agreed to bring their money, their medicines, their R&D, their activism, their resources to accelerating the elimination and control of 10 of these diseases. Because the medicines are there, these are diseases that can be treated, but that's far from the whole story. And I use this as an example. So this was announced in January of this year, and implementation is underway. And we have actually a dedicated team in our company that works on this. But I wanted to illustrate it as a way that pharmaceutical companies participate from a human rights perspective on the people who are the most neglected, who don't have necessarily a political voice, and very often are outside the healthcare delivery system. And from a mind map perspective, from a mental map perspective, if that's the values of what many people in these businesses think, then what an opportunity we have to unlock that in how we run our business, in how we invest in R&D, and how we can be partners to the stakeholders in the countries to make sure that healthcare is delivered.
Thank you, Ellen. As we were preparing these talking points and this interview, you were sharing with us how you've redefined some of your business model, how you've partnered with Pfizer, two companies to address a particular issue, and how you are rethinking of access to vaccines across other stakeholders. So I think that is very valuable, and I don't know if you could elaborate with us how you are rethinking your business models to help humanity fulfill the right to health.
Okay, so two thoughts here. So one is, I'm sure everyone in this room is aware of the GAVI Alliance for Vaccines, the Global Alliance for Vaccines and Immunizations. And a little bit of history here with some coaching from my friend Manu in the US. But in the 80s and 90s, there was actually a crisis among immunization in children. The vaccines were available in a way they hadn't been before, but production was falling off. Companies were exiting making vaccines because of the tremendous pressure to provide them at a reasonable price. And going back again to a theme that was mentioned this morning, this was a dilemma. Vaccines they're costly not only to develop, but they actually cost a lot of money to make, and they do have to be made very well, because the most vulnerable people, kids, have to get an absolutely sterile and secure product that's going to change their immune system. This is not a trivial thing. And so companies were just exiting doing this because the pressure was so high on the prices. But of course, that's also a dilemma because not every country can afford these things. So in around the year 2000, the Global Alliance for Vaccines and Immunization, the GAVI, was formed. And GAVI consists of a group of stakeholders that are representatives of industry, of the financial sector who donate the money, and of course, people in public health and the WHO. And the result of that work is a tiered pricing system that every vaccine manufacturer, every major vaccine manufacturer in the world adheres to. And so just to give an example, at GSK, we do make a lot of vaccines. We ship about 1.4 billion doses a year. 1 billion of those go to developing countries. 50% of the volume earns 3% of the revenues. But that's only possible because there is a global endorsement of tiered pricing, and financial donors have stepped forward to supplement that. So that's part one of the vaccine example, and now I want to give you part two. So I told you about vaccines that already exist for children. So what about new ones? Why should Africa wait 10 years to get a new vaccine for pneumococcal disease? It isn't any less prevalent there. So this was a problem that was wrestled with about 3 or 4 years ago because, again, because of the cost of making a vaccine. So if the vaccine works, to scale up so that the whole world could get it at once, how could you do that? Well, the GAVI Alliance, working with financial partners, worked out something called the Advanced Marketing Commitment. It's an AMC mechanism. Donors came forward with money and said, we will guarantee your price. But of course, the price for countries that can't afford it has to be X. And the company signs a legally binding contract that says, if our vaccine works, we will provide at this price for these 25 countries at the same time. We will build a factory to make sure when it's launched, the whole world gets it at once. A company could not build a factory in Singapore and make a 600 million pound investment if they didn't know the money would be there. But now the money's there, so the commitment can be made. And the pneumococcal vaccine, and this is just a GSK example, but there are other examples. Those commitments have been fulfilled in the last 18 months following this launch. So here's one example of how we run a business. We absolutely must at least have our own costs, and if our shareholders aren't going to invest if there isn't some price. but that's agreed with global endorsement. It's not equal, but countries are not equal with regard to GDP. That's acknowledged. And this again comes from the human rights perspective that no child should miss their immunizations in a world where these things exist, and that for pneumococcal disease, no part of the world should suffer for 10 years while we wait for enough money to roll in to build the next factory. So that's one way we have been able to alter our business model with the global community as endorsements. I do have another example, but is it going too long?
No, we have another 5 minutes before we open up.
Okay, so I'll try to do this one quickly. So I've actually talked about more global things, and I'd want to talk about one thing specifically. So inside your own company, how do you change things? What we were realizing is that we operate in 135 countries in the world. That's where we sell medicines. We have organizations in 85 countries. But it was clear to us in less developed countries that what was happening is that our medicines that could command a good price were getting to the very few. And lots of other people who could benefit from these medicines were not receiving them. So in 2009, we created a business unit called the Developed Countries Market Access Unit. It's the 50 least developed countries in the world. That's about 800 million people, more than half of them who live on less than $1 a day. And we have restructured the business so that the people get paid based on how well they do for volume, not for price. And suddenly, you have a very different way you want to make sure medicines get to people. Now, we weren't 100% sure this was going to work financially. For generics, we put those at cost. For our ethical medicines, we took a price cap of 25%. But and then we said to these governments, by the way, we understand that if we're going to make money here, you guys have other problems. So GSK takes 20% of the profits from this business unit and reinvests it in the countries for healthcare capacity building. So we've actually made a very public commitment as to the level that we're going to reinvest in the countries involved and what we're going to do with that. And that, by the way, is handled through third parties, so we don't administer that. Our NGO partners support us in that. And so we actually changed how we do business, in 50 of our countries of the world. And in its third year, I'm expecting, I could knock wood, but this business unit will be, in the positive zone for return of investment. It's certainly not going to be the return on investment of other parts of the world, but we have an ambition to grow volume, and we have already covered 30 or 40 or 50% more lives with access to medicines based on this. So it's one way inside the company we're looking at running the business differently. And there's probably more ideas to come like that. So to go back to the question that you asked me at the very beginning, Leo, when we first talked about this, I don't really have all the answers to how healthcare companies can participate in access. But I just wanted to share with you at least some of the ideas and the ways we've participated. And I'm hoping in these next few days I hear about more.
Thank you, Ellen. Thanks a lot. It is definitely not only again, private sector, pharma industry should be part of this conversation with rights and duties as well.